هلا دكتور طارق، السلام عليكم. طارق.
الو، السلام عليكم.
اهلا فخر ليستر.
انا شايفني سامعني.
يا سلام، ايه النور ده كله؟
ده نورك يا باشا والله.
هلا هلا فيك.
طيب،
منور
اعمل
والله.
شير سكرين كده اشوف.
اه يا ريت.
عامل ايه يا باشا؟
فضل ونعمة، جميل الحمد لله يا باشا.
ازيك يا رحاب؟ اعمل انتار سكرين. شير.
نعمل شير كده، ايوه.
تمام.
تمام.
شايفين كده؟
ايوه. impact of antenatal corticosteroids when preterm infants.
امم
هي دي.
ماشي. بس احنا بنقدم ونأخر بس.
تمام. ممتاز كده، احنا جاهزين. صوت
اتحرك
جميل.
كويس، شايف الحركة؟
كله تمام، كله اخضر في اخضر.
تمام. انا كده برضه صورتي طالعة معاك كده ولا؟
عسل خالص.
طيب، والقميص عامل شغل؟
القميص لا عامل حلو، الكروات ده جميل، ده ابيض في اسمر كده حلو. حلو الدوائر. حلوه الدوائر بالكتف دي.
ايه؟
حلوه الدوائر اللي على الكتف دي.
ايه رايك في الدوائر دي؟ عشان يبقى الواحد ينشن عليها كويس. تمام كده البداية هنا.
احنا جاهزين 6 دقايق ونبتدي. هنخلينا
طيب،
على
انا
كده ست
خليني
دقايق
كده
بالظبط.
بقى وما نبدأ. قول
ايوه.
لي ها.
6 دقايق بالظبط. اقفل بقى الصوت بس والصوره.
اقفل الصوت والصورة ثانية بس،
اه.
انا اقفلها ازاي؟ اروح
6 دقايق
هنا.
ونبتدي ان شاء الله لما ناخد الاوكي من امير، وباقي الشباب يبتدوا
طب انا
يخشوا ان
كده
شاء الله.
اعمل ميوت اهو.
اه بس. تمام. واعمل السكرين كمان للفيديو. كلوز للفيديو خلاص.
اعمل ستوب شيرنج ولا اخلي الشيرنج؟
خلينا زي ما احنا علشان نبتدي على طول.
طيب تمام، اقفل الفيديو بس دلوقتي. تمام.
ثواني ونبتدي إن شاء الله يا شباب. بسم الله الرحمن الرحيم. نعود كده يا دكتور طارق.
ايوه.
جاهز؟
انا جاهز. تقول لي بس افتح
افتح
المحاضرة
يلا.
على طول.
يلا افتح المحاضرة عشان أقدم حضرتك. نبتدي بسم الله. بسم الله الرحمن الرحيم. نبتدي يا شباب على بركة الله. جاهز يا دكتور طارق؟
اه جاهز.
السكرين جاهز؟ تمام. الصوت جاهز، الصورة جاهزة. بسم الله الرحمن الرحيم. أهلا وسهلا بحضراتكم في منتج جديد من منتجات المؤسسة المصرية لأطباء أطفال مصر، بالتعاون مع طيورنا المهاجرة في المملكة المتحدة، وبتنسيق جميل من دكتور رحاب الصعيدي. بصراحة يعني قعدنا نفكر إيه اللي نقدر نعمله، فقلنا إن إحنا لازم خبراتنا وحبايبنا وزملائنا وأساتذتنا اللي موجودين في إنجلترا، يعني نحاول نشوف إيه الدنيا ماشية حوالينا إزاي، ونحاول نعربها نمصرها شوية بحيث إن إحنا نطلع على الخبرات. نبتدي النهاردة إن شاء الله مع البريتش ويل، مع أخ عزيز وجميل خفة دم وعلم. طبعا يعني على مدار سنين أنا أعرف دكتور طارق. دكتور طارق فورمر نيوناتولوجي كونسلتانت في بريدة القصيم، الام سي اتش، ودي من اكبر مستشفيات المملكه السعوديه. يعني فيها حوالي 80 حضانه تهيألي دكتور طارق.
ايوه مظبوط. كانت 80 بيتس.
حبايبنا كلهم هناك، كانوا هناك. لسه الحلواني هناك واحمد حداده كان هناك وبعد كده دكتور طارق كان موجود وسافر انجلترا. دكتور طارق كمان بسم الله ما شاء الله اخذ اووردد بصراحه في ليستر يونيفرسيتي، انه ذا بيست اديكيتور اوورد ان يونيفرسيتي هوسبيتال. فده شيء يشرفنا كمصريين، ومش بعيد على دكتور طارق. هو راجل محب للعلم، وبسم الله ما شاء الله يعني اللي متابع دكتور طارق كويس هيتابع كمان حلقاته في رمضان. وخواطره الإيمانية كانت جميلة، أنا كنت متابعها طبعا. سعداء بحضرتك يا دكتور طارق وسعداء بوجودك، وأكيد هنستمتع النهاردة. شكرا لكل المتعاونين من الزملاء اللي هيبقوا معانا على مدار الحلقات في البريتش ويل. شكرا لدكتورة رحاب على التنسيق. دكتورة رحاب من الناس اللي هي بتحب برضو أول ما بندي فكرة بتحب تطبق بسرعة، فكانت على طول عملت كونتاكت مع الزملاء ويكونوا على طول حاضرين ونفذنا. شكرا لأمير ومي ومحمد هلال وكل السادة المودريتور اللي هيبقوا معاكم على مدار البريتش ويل. احنا بس الإعلان اللي احنا أعلناه ده البداية لأول مجموعة، وبعد كده إن شاء الله هيبقى فيه لقاءات دورية ومستمرة إن شاء الله. دكتور طارق شاكر وجودك وأكيد هنستمتع. اتفضل المايك معاك.
السلام عليكم ورحمة الله وبركاته. سعيد جدا بوجودي مع البريتش ويل والاي يو بي. دي تقريبا ثالث برزنتيشن ليا مع الاي يو بي. كان الاثنين برزنتيشن اللي فاتوا كنت ايام ما كنت في السعودية، ودي هتكون اول واحدة واحنا هنا في بريطانيا. Um, I hope I will meet your expectation for this presentation. I tried to present on Prezi, which is I like it a long time ago. I hope you will enjoy the presentation. وأتمنى نكون عند حسن ظن حضراتكم. The title of the presentation is Neonatal Ventilation. The
باشا
past,
شد الحيل
the
كده،
present.
شد الحيل معانا كده في الصوت، الله يبارك فيك.
نعم.
شد الحيل في الصوت شوية كده،
يعني
نعلى كده
أزود
شوية كده
الصوت
عملنا. اه يا ريت، يبقى كتر خيرك.
ولا تمام إن شاء الله؟ يعني أعلي صوتي أنا بقى.
اه علي صوتك بقى معلش، اتفضل.
So the title will be the neonatal ventilation, the past, the present, and the future. This is a comprehensive review of the historical advances in the current strategies. Advances in the respiratory support for preterm units. This presentation outlines significant milestones in the evolution of lung protective respiratory strategies of preterm neonates, detailing the innovations that have improved survival and reduced morbidity over the past 5 decades. Key strategies such as antenatal steroids, surfactant therapy, modern ventilation techniques are emphasized as critical components in enhancement of the respiratory support for this vulnerable population. Uh, I will talk also about the low limited resources in the units. Especially, I have witnessed a debate about delivering premature infant like 24 weeks or 25 weeks in district hospital in Egypt, or hospitals which is not qualified to deal with such tiny babies, even for stabilization or for following these babies and growing them in the neonatal unit. So it will be interesting subject for debate and discussion, because this is really touching, and from the ethical point of view and from the religious point of view. So the evolution of neonatology, significant decrease in mortality, and for any units or for any subject, if you see any article, they will outline the outcomes. The mortality, one of the outcomes for the neonatal morbidity and mortality. So it is not only we are measuring our development with only measuring the survival and the mortality. Also, for any the primary outcome always include like the IVH rate, interventricular hemorrhage rate, BPD, pulmonary bronchopulmonary dysplasia or chronic lung disease, ROP, retinopathy of prematurity, like NEC rates, necrotizing enterocolitis rates, and also the neurodevelopmental outcome, which is the main component in the future life. You will see advances in the research, and if you following any of the scholars, you will see a lot of articles. Like I recommend like QX Med, one of the things you follow any journal, and you'll be surprised with the articles and how many articles published in on daily basis. Also, another way to follow like one of the scholars that you hear their names in the article or in the presentation, and just follow them on Google Scholarship, then you'll get all the articles they recite. So it is, you will be updated with what they need on they read on daily basis. This is one of the recommendation for you, is to follow the scholars in Google, and the recites article, then the article will come to directly to your email. Uh, then we'll talk about standardization of care. This is very important point. Why? Because this will touch the debate which I mentioned about what things that improve the neonatal outcome. They initially mentioned the right place of birth. So when we call about standardization of care, that this is the things that every unit are willing to do it. So the right place of birth is the best thing to start with. Like if I have a 25 weeks and born in district hospital or like a rural hospital in any underdeveloped country or developing country, the good thing here is the system. So they categorize the levels of the neonatal unit to level 1, level 2, and level 3, which is the tertiary care. Level 1 hospitals only can deal with deliveries more than 32 weeks. Level 2 hospital can deal with 28 weeks and above. And tertiary care hospital, which like the hospital which I am working, which is Leicester Rare Infirmary, they deal with babies like from 22 weeks and above. So the the standardization of care begin with the right place of birth. I cannot like deliver a baby with 22 weeks in a level one hospital, which they can only apply CPAP, or they can intubate, and they can shift the baby later on. So moving the baby from a level one hospital and to a level another hospital, especially these tiny babies carrying the risk during transfer of developing intraventricular hemorrhage. So they started. And I like the system here in UK because the transport system and the communication between the unit is super actually. Because I remember my days in first days in Egypt when I was intern or house officer. We working on the emergency department, and we saw babies like premature babies carried by their parents on their lap and coming by a very tiny paper which is telling, dear colleague, this is a preterm baby, you need an incubator. And the parents was like the family traveling to all the hospital. At the end the baby will arrive dead. And here this will not happen. Like here there is a system. If the baby delivered in district hospital, you call the transport team, you arrange transportation to other hospital. So this is the first thing that we should work on it. And I will have a talk about low resource, like the small talk, how to improve this. Then we have one of the things that come for standardization of care is the antenatal steroids. This is well known now, and the American Academy of Obstetric and Gynecologists and the Royal College of Obstetric and Gynecologists updated their guidelines on 2023 and 2024, which mother should receive the antenatal steroid. Initially, now we are reaching 22 weeks, restricting 22 weeks gestational age, and all the guidelines was talking before about 24 weeks, and now it changed it to 23 weeks suspected delivery. I was like, although I work in Saudi Arabia for a good time, almost 14 years, but it was my first time here when I came here to see how they predict the preterm labor by doing some tests to mom and cervical length and I was surprised actually. They call you, the midwife will call you. We have a lady 24 4 weeks with this test is positive and she may deliver now. And then I asked Mike, what is this? Anyhow, the antenatal follow-up, good antenatal follow-up definitely leads to good outcome. So we talk about the right place of birth. We talk about antenatal steroids. Then we talk about magnesium sulfate to the for mothers, which link it to improve the neurodevelopmental outcome. If you give like 31 plus 6 up to 31 plus 6 expected deliveries, so you can give mom magnesium sulfate, which will improve the neurodevelopmental outcome because they found it decreased the rate of cerebral palsy. Then after that, we come to encouraging mom to express her breast milk after delivery of the baby. This is one of the like standard of care because of we are aiming to give buccal colostrum even in the first 24 hours for the tiniest baby, 22, 23, 24 weeks, whatever. So the buccal colostrum carry a lot of advantages, especially boosting the immunity of these babies. We are not giving feed; we are giving only like to stimulate the oral mucosa and you give stimulate the lymphoid tissue for this tiny baby to boost their immunity. So breast milk is very important, and deviation from the nature is the worst thing that we can do. So breast is still the best, and we encourage mom to express their milk after immediately after deliveries, and we give this premature baby express breast milk. Also, there is harvesting of the colostrum. Like mom, she knows that she will deliver prematurely. They encourage the mom to even harvest her breast milk before delivery, but this carries the risk of stimulating the uterus and induce premature deliveries. The other things that any mom that go to preterm delivery, they offering to her the antibiotics, during labor antibiotics, and also we now baby delivered. So the first thing we do is delayed cord clamping. This delayed cord clamping you have it is when I was NRP instructor, the delayed cord clamping was 30 to 60 seconds. Here, as NLS guidelines, delayed cord clamping was almost for 1 minute. Delayed cord clamping carries a lot of benefit for the premature infant, we are not seeing now hypotension like before, because 40% of the placental blood moved during this period after delivery. The immediate cord clamping, unless the baby really need resuscitation and baby is floppy and have no chance for to do delayed cord clamping. Also, they are talking now about resuscitation while cord intact, and this is need some elaboration about it, because it is actually helpful. Uh, but this in case of the babies who need resuscitation, so we can resuscitate them while the cord is intact. But delayed cord clamping became now standard of care, reducing the incidence of IVH. And no need for hypertension, treating hypertension as before, decreasing the risk for repeated blood transfusion. These preterm babies receive a lot of red cell transfusion, but with delayed cord clamping, at least you postpone this after the first week or second week. There was a talk about decreasing the incidence of NEC, but this is not approved. So the delayed cord clamping didn't reduce the neck, but reducing the incidence of IVH, and is very like one of the things that I like it in the neonatal practice for this delayed cord clamping. Also, after the baby delivered, maintaining normothermia is very important. This is standard of care to maintain the temperature during and after the station between 36.5 and 37.5. And this is a very good quality improvement project to measure the temperature after delivery and when you admit the baby to natal note, because every baby is less than 28 weeks, premature baby, every decrease in the temperature by 1 degree increasing the incidence of death up to 28%. So it is very important to maintain a normothermia for this baby. I was always mentioning to my colleague the dilemma of if you admit the baby hypothermic to the unit, they'll have metabolic acidosis. Then they said, oh, metabolic acidosis, then give bolus saline, which is not recommended, or give bicarb. And all the problem was started because of hypothermia, high lactate because of hypothermia. So maintaining normothermia is very crucial for this baby. Once baby admitted to the neonatal unit and need ventilation, now all talking about targeted ventilation, like volume targeted ventilation or volume guarantee. So just like we accept 4 to 6 ml per kilo for this tiny baby. You can start with 5 ml per kilo, 6 ml, and when you have more tiny babies, the anatomical dead space is more, so sometimes you need more tidal volume, like 6 to 8. So and you can assess the compliance on the ventilator, whatever. But now the targeted tidal volume, one of the ventilation protective strategy,
دكتور طارق.
helpful for this time. This is one of the standard of care. We talk about ventilation, then we talk
معلش
about
يا دكتور طارق
free.
لو سمحت.
الشاشة ثابتة يا دكتور طارق.
Sorry.
البرزنتيشن بس احنا واقفين عند standardization of care، ما
ما
فيش.
كل ده كلام للستاندرزيشن، يعني ما
طيب
فيش.
تمام، اوكي.
تمام، ممكن
just
حضرتك
talks.
تضغط يا دكتور طارق على كلمة هايد تحت كده.
Okay, we are talking about only standardization. So because these are 10 points on the standardization of care, we reach to the point number 9, which is TTV, and which is point number 8 was targeted tidal volume. Then we have point number 9, which is caffeine straight. Point number 10 is probiotics. We give probiotics to our tiny baby just once they started minimal enteral feed. We give them probiotics. So we'll go for the historical development in lung protective strategy for preterm neonates. We have the key milestone, which started on 1960. And you'll be surprised, the journey for neonatal management started on 1960, and they start to know highlighting the crucial discoveries such as the recognition of surfactant deficiency in preterm infants. And then we have the death of Patrick Kennedy, the son of President John Kennedy, and his wife. And if you know that Patrick Kennedy died at 34 weeks gestational age, and his birth weight was 1.8 kilo, and imagine now we are stating babies 22 weeks, and like in Japan they have a survival 280 grams, which was the tiniest baby who was survived. Imagine Patrick Kennedy died because of RDS with weight 1.8 kilo, and now we are resuscitating babies 22 weeks gestational age, and the tiniest baby who was graduated from the NICU in Japan was 280 grams. A big and a lot of improvement, a lot of difference came from 1963 till now. The Japan is, we always calling the planet of Japan. Japan is starting rotating preterm babies 22 weeks since 1990. So after 30 years only from this event, Japan rotating babies 22 weeks, and they have the best outcome for these tiny babies, and even the survival rate in Japan. And this is like, you don't, we have like, this is not the benchmark, but they are Japan, but they are the least mortality rate. They have survival rate for 22 weeks gestation 80%. This is too much. This is great improvement in the neonatal care. Then we have 1971, the introduction of continuous positive pressure, which is CPAP. I like this picture. This is one of the fathers of CPAP. You can see his picture on the right side on 1973. And this is the picture with him. We met in one of the conferences in Dubai. This man loves CPAP. He likes CPAP. He Everything in his life is CPAP. I took him talked with him about surfactant. He said CPAP first. About ventilation, CPAP first. This man, see, and when I like thinking that I did like I'm doing something good in the neonatal practice, then I look to these people who really like influence the practice, and they added a lot. So we feel that we are very, very small, and we cannot say I'm the best, I am good, I'm doing. These people really, yeah. If you compare yourself with such people who really since long time working in the field, and they enrich the practice to the degree that we are following their steps. So this man really, this is called Jen Tian Wong. He's a professor in Columbia University in USA, and this is, see, they invented the CPAP on 1971, and he was in the picture managing baby on CPAP on 1973. It was my luck to meet this man. So this is one of my picture on our babies. She was a preterm baby in here in UK. She's now, as you see, she came to visit us in the World Prematurity Day, and this is the communication between the hospitals and the parents. So it was. I am wearing the shirt which they distribute to us on the 17th of November, which is my birthday also, the World Prematurity Day. So CPAP improves the survival of tiny babies, and this was a great innovation in 1970. CPAP also decreased the need to intubate these babies, and we'll talk about surfactant later on. So the communication between hospitals and parents. 1972, they start the antenatal corticosteroid talk were shown to enhance fetal lung maturation, reducing the incidence of hyaline membrane disease. Very important. We talk about antenatal steroids. In 1980s, pioneering trial establishing the efficacy of surfactant replacement therapy, fundamentally changing the management of hyaline membrane disease. So if you talk about surfactant, like for me, because when we joined the neonatal field, and I own all what I learned for Saudi Arabia, actually, because I was neonatology resident in Egypt, but unfortunately it was like level one, even less than level one neonatal unit. We have only managing babies with oxygen. We don't have CPAP at that time, only phototherapy. Any baby we didn't know, like cardiac, a lot of unknown causes, a lot of deaths. Actually, when I went to Saudi Arabia, it really, I own what all I learned for my hospital, which is maternity and children hospital in Breda. We, I have learned a lot of things. I had the, I started there, which I, oh, what is this? Ventilation, pneumothorax, surfactant, which the thing is that I never use. This was 2006. I joined the natal unit there in 2007, and since that time, uh, my career progressed in natal unit. Initially, uh, I don't know anything about ventilation. Then, by time, I was giving lecture about ventilation, about resuscitation, about intubation, skills, improving, and 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 this is the problem when you start on a hospital. Like unfortunately, we don't have the justice in education. Like in Egypt, we have like teaching hospital, we have university hospital, we have Ministry of Health hospital, and there is a total like difference between all the grades. And but by presence of you people like E.U.P and coming also the British Wheel and a lot of people who want to improve the practice, this will make the improvement, because building start by teaching them nicely and how to deal with uh, all the situation. So we'll talk again about surfactant trial. Surfactant improves the survival rate. Surfactant decrease the need of mechanical ventilation and decrease the length of stay in mechanical ventilation. And surfactant became adopted now one of the standard care in managing premature babies with respiratory distress syndrome or hyaline membrane disease. Uh, then we go for 19 development of sophisticated mechanical ventilation techniques aimed at minimizing ventilator-induced lung injury, led to improve the outcome. Uh, I also I think I feel that I'm lucky because I work with ventilators that only provide CMV. Then we have upgraded to one of the machines called Pear Cup machine, which had a lot of modes. Then we upgraded to the Dragger machine. Then after Dragger, we work with Macket, which is a servo eye, which in my opinion, one of the best ventilators ever. Then we have SLE. Before the servo eye, we have SLE 5000, and we have also sensor medics for high frequency, and then Fabian ventilators. A lot of change, a lot of sophistication happen, and a lot of change in the mechanical ventilation. And you cannot believe that the flow sensor, which we adjust, we're calibrating the flow sensor. This is make this such innovation in the practice of the neonatal ventilation and reducing the ventilator induced lung injury. In 2000s, emergence of non-invasive respiratory support strategies, including like CPAP, PIPAP, DUPAP, high flow nasal cannula, high frequency ventilation reshape the neonatal outcome, because high frequency, although it looks something difficult, but it is gentle, one of a kind of gentle ventilation. To I can say one word for high frequency is a big CPAP machine, and there is as oscillation around this map. So see, high frequency is a gentle ventilation. We'll talk about ventilator-induced lung injury later on. Then in 2010s, the focus shifted to optimizing oxygen saturation. No one working in the neonatal unit and don't know the studies that targeted the saturation, how saturation target we need, like for preterm infants, and the studies which compare lower saturation target like 88 to 92 to for the studies 92 96, and even they went further. So when they aim for lower saturation target, they have good eyes, no retinopathy of prematurity, but a lot of mortalities. But when they targeted more saturation, they have a lot of survivals, but a lot of ROP. And definitely we have a lot of survival. And now we targeting most of them between 92 and 96. And sometimes in special situation, we are targeting 88 to 92. We'll go for the next slide, which is talking about ventilator-induced lung injury. I like to talk about if any one of the audience can tell us about what you know about what kinds of ventilator-induced lung injury you know. Is it allowed anyone to answer? Hello? Anyhow, so when you ask anyone what is the ventilator-induced lung injury, they will talk about first they will tell you paratrauma, volutrauma, then they said oxygen, then stop, okay, atherectotrauma, maybe they said pyotrauma, and rheotrauma is the end. Always forgetting, always the people forgetting the rheotrauma. We if you so see this diagram, so if you mechanically ventilate a preterm baby, so what you can do, you can do biochemical injury, and you can do biophysical injury by distending the alveoli. And over distending the alveoli will can lead to cystic stretch, increase intrathoracic pressure. Then you can do also the systemic manifestation because you cause tissue perfusion injury. So it is not only because you can damage the lung, and also you affect the systemic circulation by decreasing the organ perfusion. Atherectoc trauma is the trauma caused by ventilating some areas of the lung and some areas of the lung having atelectasis. So it will be very difficult in heterogeneous pathology like meconium aspiration syndrome if you ventilating this baby. So you need to understand the pathophysiology, and from understanding the pathophysiology, you adjust your setting. You know what to do. You need to know what is the ball and valve mechanism. You need to know what inspiratory time is suitable for meconium aspiration baby, what pressure is suitable, what PEEP is possible, what inspired time is possible. Not ventilation is not only increase the pressure, decrease the pressure, increase the rate, decrease the rate. This is not ventilation. Ventilation, you need to understand the pathophysiology of the disease which you are ventilating. RDS is a homogeneous pathology. Stiff lung. What is the best inspired time for a stiff lung? What is the inspired time? What is time constant? What is the pressure? What is PEEP to open this lung? What surfactant will do? What after surfactant? What I should care of? So paratrauma, when you give more pressure, you can lead to air leak syndrome like pneumothorax, emphysema, pneumodystinum, which is part of the paratrauma. Volutrauma is the most common one, and like the most devastating one, because pressure because when you're delivering pressure at the end, this pressure will be changed to volume. So volutrauma, which is can cause all of this trauma at the end, cause pyotrauma and the release of chemical transmitter like cytokines, complement, prostanoids, leukotrienes. Then if the baby is infected, so adding bacteria to this, so the lung lady will be totally damaged. Rheotrauma is the trauma caused by the flow. And don't forget this trauma, please, because the first thing that you adjust and when you connect the baby on a ventilator, you calibrate the flow sensor. The microprocessors in the flow sensor is the only thing that giving feedback from the patient and the machine. And this microprocessor, the flow sensor, adjusting the flow every second to deliver what you need from tidal volume, to deliver what inspired time you need, to when you terminate the pressure, when you to how much inspired rise, how much percentage. And the only machines that you can adjust the inspirator rise is the servo eye. That's why I like this machine. I never see the inspirator rise in any machine, only the servo eye. So RIA trauma, remember that the most common traumas, ventilator-induced lung injury is the volio trauma, paratrauma, atelecta trauma, pyotrauma, and rheotrauma. And rheotrauma is the trauma by flow. Sometimes, like babies just born today, put on ventilator, after 2 days, we find PIE picture. We don't know why. Why they have pulmonary interstitial emphysema after 2 weeks? Why they have evolving, a very rapidly evolving chronic lung disease? I think because of the flow. If we are not caring with the pressure or tidal volume we are giving, the flow is going, especially if we are not using cuffed tube and there is leak, and the ventilators try to compensate this leak, giving sometimes more flow. So we need to care of, it's not only put the baby on ventilator, but you need to take care of what you can induce from the injuries because of this ventilation. Especially, it is a very tiny lung, and you will see now the development of the lungs. The impact of antenatal corticosteroids, this is very important. The corticosteroids is very, we said, very crucial, because this will decrease the incidence of IVH, decrease all the grades of IVH also. So it is standard of care to give antenatal steroids. The best period to give is more than 24 hours. Betamethasone is favored than dexamethasone. Betamethasone only 2 doses. You give 24 hours apart, and it's 6 milligram, sorry, 12 milligram per kilo. And dexamethasone is 4 doses, and you give like 12 hourly, and at 6 milligram per kilo. Betamethasone is favored. Betamethasone is a rescue one. So we started to give dexamethasone, sorry, antenatal steroid for expected preterm delivery, and the timing is very crucial. You can repeat the dose if more than 1 week passed, or more than 2 weeks passed from the dose you gave when you expect preterm labor but didn't happen. So this is you always, when you have like morbidity mortality meeting with the OB-GYN team, just discuss what we are doing on the antenatal steroid. Are we very close to the benchmark for antenatal steroid? Do we do an antenatal? The problem in our countries, we depend on the private sector, and the antenatal follow-up did totally different from here, country like UK, or Saudi Arabia. The antenatal follow-up is very important. The 20 weeks anomaly scan, the following up scan, the measuring of the baby, the delivering, a lot of things like Doppler, a lot of things is very important. Now, the antenatal follow-up make our life easy. Uh, Now I have like what is called baby delivered, and we have neonatal letter with the baby that this baby having coarctation. Please start protein once the baby delivered. So our life become more easy because of the improvement of the antenatal follow-up. We have like this baby will be born by bilateral linear pelvic dilatation. You need to admit or rule out BUV, start prophylaxis. All these things initially we surprised to find a baby cyanotic or needed. Now most of the babies born with cardiac anomaly, we know them before even delivery. So key impact of surfactant therapy. So if you see here, this is surfactant kit, which I use surfactant a lot in Saudi Arabia, but we always using the NG at that time. And every time when I was reading about surfactant, they said don't use like NGs, use always the surfactant kit. And the first time to see the surfactant kit here in UK, but we give a lot of surfactant with NG if you don't have this sketch. So Now the evolution of surfactant therapy. Do you give surfactant Ensure? You give Lisa? You give Misa? You give Salsa? So now this is a improvement. Like initially we intubating babies, giving surfactant. If they need intubation during gestation, gives them surfactant. Initially there's a prophylactic surfactant and rescue surfactant. Now we are trying to minimally invasively give surfactant. We have the Lisa, which is less invasive surfactant and administration. We have Misa, which is minimally invasive surfactant and administration. It's almost the same, but the caster shape is different. For Misa, the caster, Lisa caster, is curved towards the vocal cords. We have salsa. Even now, we are giving surfactants through the LMA. And also, before that came the Ensure, like intubate, surfactant, then extubate. So this is a lot of improvement even in surfactant delivery and surfactant administration. Now we put the babies, initially we put any baby, okay, RDS gives surfactant, especially for the countries like don't have a problem in money, surfactant available everywhere. So, but now they put the baby on CPAP, shake the baby, FIU2, work of breathing, they need surfactant or not, because we are not giving now prophylactic surfactant most of the time. So we go by clinical, go by FIU2, then second dose of surfactant, how we babies need second dose or not. Some, but generally speaking, if the lung is very bad and this lung needed a lot of surfactant to be given, this is carries also the worst outcome. That because the lung was very bad, that's why you give lung more surfactant, but this linked to more BBD. Surfactant reduce the mortality rates, the long-term benefit we know of decreasing the length of stay, but always goes clinically. And we said non-invasive first, then if baby is not breathing or fail, then intubate, connect to the ventilator. The baby needs surfactant or not according to the clinical, not according to the chest X-ray. So chest X-ray or ultrasound coming later on, but clinical situation of the baby is the most important. So this is adopted as a standard of care for treating RDS, reduce mortality rates, and long-term benefit beyond immediate care, because also like we talk about outcome. So the bronchopulmonary dysplasia, one of the main outcome when they think on giving surfactant or not giving surfactant, invasive ventilation or not, non-invasive, all these things to be considered, and all depend on the clinical situation of the baby. BPD is a complex things, bronchopulmonary dysplasia, and we saw a lot of BPDs, not like before, because the improvement of the survival rate. Now we saw babies 23, 24, 22 weeks. Actually, the survival rate in UK is only 20%. Every, like, for 22 weeks, like 8 over 10 may die. So the chance of survival only is 20%, and even survival babies have like 1 in 3 chance to have a severe neurodisability. The outcome is improving by age, so as 23 weeks is better, 24 weeks is better. To reach up to 26 weeks, the survival rate is 80%. So survival rate in UK for the 26 weeks is 80%, with less neurodevelopmental disability. If you a unit and you have treating babies with premature baby like 24, 25, 26, you should have the follow-up, and you have even many of these babies go home with oxygen. So who will follow up at home through like home care team here in UK, chronic lung disease clinic. So it is not only I can deliver 20 weeks, 25 weeks, or 24 weeks. Oh, let's deliver. No, how I cannot transfer this baby? Because you know the impact of the impact of chronic morbidity on these babies, and the impact on the family. Like even here, I saw a lot of like divorces because of the mom carrying with a preterm baby stayed most of their life. Like I saw mom stayed in the hospital 5 months. What a social life she had. how like it's very the outcome is definitely matter. So don't say, okay, we are not baby born 25 weeks in our hospital, unfortunately baby kept there, we cannot transfer, because we don't have the right place of birth, we don't have the right system to transfer this baby to other unit level 1 or level 3 or level 2. So it is not like just deliver, just resuscitate them. It is the impact on the family, impact on the baby, impact on chronicity, the impact of how you follow up these babies, ROP screening, IVH screening. If they have a chronic lung disease, go home on oxygen. How to support them with home oxygen. How to follow them on a chronic lung disease clinic. BPD is still one of the major problem, and it became like rising because of now we have a survival of 22 weeks. So imagine they stayed on the neonatal unit for a long time with respect support. Definitely they have um, chronic lung. So I had some of the X-ray. So this baby, like initially admitted with RDS, AT tube in place, improved. Baby, he improved, but this baby, unfortunately, he developed chronic lung disease. This baby developed early PIE changes, honeycomb appearance, and ventilating this baby, the strategy is totally different. If you have saw this baby with pulmonary interstitial emphysema, which area of atelectasis and areas of hyperinflation, a very bad heterogeneous pathology. So if you don't understand the pathophysiology of this, how you ventilate them? Here, baby also with patchy atelectasis and this chronic lung disease. How is ventilation for this baby different from ventilation of this baby? Totally different, yes. Baby with RDS, you need strategies, totally different strategies. Not all the mood fit one baby, not all the pressure fit one baby, not all the inspired time fit one baby. So we managing babies on ventilator depend on the pathophysiology. This is very important. Anyone in the neonatal unit should know how the embryology of the lung, and because if imagine we have the embryonic phase, which is 3 to 7 weeks, pseudoglandular first 7 to 17 weeks. Then here the problem will start for the canicular phase. Imagine you have a baby developed 22 weeks or 23 weeks or 24 weeks, 26 weeks. They born in the canicular phase, and still they have didn't complete the saccular phase and didn't complete the alveolar phase. So if you introduce ventilator injury or during this period, definitely will impact the growth of the lung, and maybe definitely will have a chronic lung disease. Then the saccular phase from 26 to 36 weeks. Then the alveolar phase, which is from 36 weeks to 8 years after birth. So imagine when you ventilating a baby 26 or 27 or 28 or 29, still the lung is not developed. And if you be aggressive with this lung, imagine how will be the outcome. We have the evolving presentation of bronchopulmonary dysplasia, because if you understand the definition, like if I have a baby was born at 25 weeks, and this baby now is 30 weeks, but still in oxygen, is the baby fit for definition of chronic lung disease? He didn't fit, but he fit for the evolving chronic lung disease, because the definition of PPT should cover two things, like 4 weeks, like 28 days on oxygen, and at a age of 36 weeks. So imagine he's 24 weeks to reach 36 weeks, how many weeks remaining for him? So if he stay on oxygen for this such period, we are calling it evolving chronic lung disease. Bronchopulmonary dysplasia has transformed from a condition primarily affecting severely premature infant to one of that now includes more mature infant who survive. This shift reflects advances in the neonatal care, particularly in the respiratory support, which have improved outcomes and survival rate. So improving the survival rate, but we have more BBD rate now. So enhancement of patient ventilation interaction, like initially We have like CMV mode. There's no interaction at all. You are giving a mandatory pressure and baby breathing, not breathing, exhaling or inhaling, inspiration, expiration. The ventilator في وادي والبيبي في وادي. ف now we are for the synchronized ventilation, for the targeted tidal volume ventilation. Also, like if you know or you work with NAVA ventilation, which is neurally adjusted, the sensor will be put in the esophagus very close to the diaphragm, and the idea is to sense the movement of the diaphragm to do the best trigger with the patient inspiration, and this improves the outcome, decreasing the BBD, and decreasing the length of stay on the ventilator. So now synchronization and triggering is the best thing that we can do. Even synchronization now started to be on the non-invasive model, like SIBVV nasal ventilation, synchronized intermittent post-operative nasal ventilation. This is very good and promising. We have the nasal high frequency. I never work with it. I hope we have the facility for nasal high frequency ventilation. Also, we have like now high frequency ventilation with volume guarantee. Also, I don't have the experience to work with volume guarantee, but I know the concept. So now there's a lot of patient ventilation interaction, and still going challenges for the BBD despite of this innovation. So volume targeted ventilation, this is now, I said this is standard of care. Once you admit a preterm baby to the neonatal unit, adjust the total volume for 6 ml. It depends on your patient. You can go for 6 to 8 ml. And the good thing on volume targeted ventilation is the auto weaning. Once you give, because you set the Pmax, and once lung compliance improves, the pressure will go down by its own. So initially you need like 25 pressure to achieve 5 ml per kilo, but after surfactant, after like 1 day on ventilator support, now the tidal volume, you don't need all these pressures. There is auto-weaning of the pressure. Now we need only 20 pressure or 18 pressure to achieve the same tidal volume. So this is one of the recommendation for the ventilator protective strategy, to put the be on volume targeted ventilation. And this also affecting the outcome for BBD. So reduces the outcome for BBD and reduces the outcome for ventricular hemorrhage. So decrease the risk of BBD, decrease the risk for interventricular hemorrhage, and reduce mortality. Definitely, we said mortality one of the major outcome, and like BBD, NEC, IVH, BBD is other outcomes. So clinical trials has shown that implementing volume targeted ventilation, so volume targeted ventilation is almost same volume guarantee. Here in UK, they name it for TTV because they said we cannot guarantee, but it is almost the same, and almost the same concept. Even it is the same concept on BRVCs, BRVC, which is on servo eye, compared to traditional pressure limit ventilation, enhancing the long-term health perspective of the preterm infants. They introducing the high frequency ventilation as a gentle ventilation. The good thing is the early intervention with high frequency, as many countries do. I am fan of Japan. The babies, some early intervention, some babies, if they stayed on ventilator support more than 3 days, they shift automatically to high frequency ventilation because of the gentle ventilation. So high frequency is non-tidal ventilation. We are not talking about tidal volume here, because the tidal volume is less than the dead space. So in high frequency ventilation, the tidal volume is less than the dead space. High frequency ventilation has been identified as significant advancement in the neonatal care, offering an alternative to conventional mechanical ventilation. These techniques allow for ventilation at much higher frequency with lower tidal volume. So we said the tidal volume less than the dead space, which is 1 to 2 ml per kilo. And this definitely decreasing the ventilator-induced lung injury like atelectic trauma, volume trauma, trauma, oxygen toxicity. Implementation of high frequency has shown potential benefit in maintaining alveolar stability and improving oxygenation in preterm infant with respiratory distress. The role of inhaled nitric oxide. So this is also some evolving thing. I am very delighted. I'm very yeah, like happy because we work with nitric oxide in Saudi Arabia, and here we are the people who started treating pulmonary hypertension with magnesium sulfate and with one of the worst medication to give magnesium sulfate infusion to baby with pulmonary hypertension, bradycardia, apnea, magnesium sulfate to achieve the desired effect on pulmonary vasodilator. It make baby totally muscle relaxed and sedated. So even when you use magnesium sulfate infusion, we stop sedation because magnesium sulfate alone can put baby on a muscle relaxant phase. Then we start work with nitric oxide. We give 20 part per million, and we saw very nice success. We have also some medication like sildenafil and bonzantan, which are all selective phosphodiesterase inhibitors and cause selective pulmonary vasodilatation. The use of nitric oxide decrease the use of ECMO. Imagine you don't have nitric oxide and you don't have ECMO, so the outcome is totally different between the units who had like the facility of nitric oxide, the facility of ECMO, and so this is how to improve. If we didn't do like a full tertiary care unit like level 3, then level 2, level 1, if we don't have this design, how to improve. And because we need justice in receiving treatment for every baby, like baby in this city have the same opportunity in this city, and this will not come unless we have a very good system of neonatal care and also transport system. We said reduces ECMO you need, but controversy about the efficacy of inhaled nitric oxide in chronic lung disease. I never saw a baby with chronic lung disease just given nitric oxide because of that, because the efficacy is controversial. Then we have later benefits of caffeine in neonates. Caffeine citrate. Also, we are the people, we work initially with aminophylline for neonates. Then caffeine came, and caffeine now is on the top list of the drugs used in neonatal units. Every unit now using caffeine citrate. So caffeine citrate is a respiratory stimulant, stimulation of respiratory drive. Caffeine therapy effectively stimulates the respiratory drive in preterm infant, significantly reducing the frequency of apnea, and this lead to shorter period of mechanical ventilation and decreased need for invasive respiratory support. But always ask yourself, why you are giving caffeine citrate if there is no apnea? Is caffeine is a prophylactic medication? No, it is not a prophylactic drug. Caffeine only treat apnea. But why you are giving our babies caffeine from the start and even up to 34 weeks? Because they find that it improves the incidence of BPD and also improves the neurodevelopmental outcome. So not only because we have the CAP trial, which was done by Barbara Schmidt, and she's done also done a lot of trials. And when I told you initially, one of the things to get the new updates, you just follow one of the big scholar like Barbara or Schmidt or Satyan or Anup Katharias. A lot of people like Ali Khufash in BDA, Satyan in pulmonary hypertension. Just follow these scholars on Google Scholar, then you'll get every article they read, every article they recite, and now you'll be updated and know how is the thing is going. So caffeine not only as a treating apnea or prematurity, but it improves the neurodevelopmental outcome. But at 5 years, when they did a study, it is controversial. But anyhow, it improve. This is improving BBD, improving neurodevelopmental outcome, and become a standard of care. So then we come to the innovation in non-invasive support, we said CPAP, BiPAP, DUPAP, and also improvement in the monitoring practice. We have like the pulse oximeter, we have the perfusion index, we have the near infrared spectroscopy, we have now POCUS, we do ultrasound bedside ultrasound for the chest, for the heart, for the abdomen, for the brain. So this is this innovation in the monitoring babies. So POCUS became, when we said point of care, we initially considered checking the blood glucose bedside is a point of care. So now the point of care changed. Point of care ultrasound changed a lot of things, like we do ultrasound chest to guide to give surfactant or not, to even to check if there is pneumothorax or not, to check even the ATT position. But this is need training and a lot of hand-on skills. For the POCUS ultrasound, I remember, and I will mention the name of Dr. Professor Mahmoud Al-Barbari, who was, this was on 2015. He's the first one to send me his presentation about chest ultrasound for TTN. Dr. Mahmoud Al-Barbari, rahimahullah, imagine now the people are talking about point of care ultrasound, and since 2015 he was have a lot of work about like diagnosis of lung problem by ultrasound, putting lines by like ultrasound guided lines. So since 2015 I have still his email with me and his presentation. رحمه الله دكتور محمود البربري كان من أعلام البوكس, one of the figures in POCUS, and he was working in Saudi Arabia or Europe. He worked everywhere actually. Rahimahullah. Then improving neonatal care in low resources settings. This is very important. You know, you face a problem of staffing. You face the problem of the nurses who can deal with babies, tiny babies. You face the problem of equipment. You face the problem of the presence of how many units you have, how many ventilators, how many CPAP, the kits available or not. You face the problem of the sterile things like gowns, gloves. Imagine you face the problem even with cannulas. I still remember that we're sending parents to buy cannulas. You face the problem of the trained staff who can deal with tiny babies. Not all the people can like intubate a 400 or 500 gram, or can ventilate, or can give parenteral nutrition, or can advise, or can shake the balance, adding fluids, decreasing the fluids, take care. There is a BDA now. We do echo to treat or not to treat. It is really big things, like, so don't think that if you have a baby like deliver in your hospital 24 weeks and you should, okay, let us rustate, let us do everything. But if you don't have the capability of to follow up this baby or to maintain his life without complications, this is the most important. So what is the benefit? Yeah, so we need to improve like our survival, like our survivor in like 28 weeks, improve our survivor first in 20 weeks, or improve our survivor in 30 weeks. Then we come, okay, well, now we are doing good, so let us go for 28 weeks. And we are going to, let's go for 26 weeks. And the system, you need the system that can help you. And I hope someone will improve the neonatal transport system in Egypt or any developed underdeveloped country to to make a helicopter view for all the units. Where is the beds empty? Where is the beds available? Which center can do cardiac surgery? Which center can do pediatric surgery? A lot of things. It is not just delivering babies and premature babies, and we need to keep them alive. It is a system. The cost-effective equipment solution, like if you have a CPAP in your unit, try to master the CPAP. You have like old ventilation machine, whatever ventilator you have. If you know the concept, you can ventilate this baby. So you understand the pathophysiology, understand what is the concept of ventilation. You understand that our aim, if we put a tube, for the first aim is when we remove this tube. Yeah. So cost effectiveness equipment. If you have a CPAP, master the CPAP. If you have like preterm deliveries in your unit, master the resuscitation of this preterm. Master the skills. Master the just this morning, I was night on call, and they called me up 5 o'clock. Not an our unit, the ECMO unit called me because they have a baby. Just they remove the ECMO caster and they need a cannula and they struggle to put a cannula for this baby. So I went there and I bought two cannulas, not only one cannula, for this baby. So the skills, if you are now pediatric resident or neonatology resident, just put your hand in everything. We were putting cannula from my first day of internship. So that's why alhamdulillah, min fadlillah, the skills are maintained. So we like, no, if it's difficult cannula, just go for it. The difficult line, go for it. So this is the skills, intubation skills. Maintain your skills, start early, start do everything by yourself, watch videos, learn from your senior colleague. We need to have the atmosphere of teaching. Like, I appreciate E.U.P what they are doing. Doing a very amazing job. These conferences, these meetings, these videos, these podcasts, something really impressive, because the idea is to teach, to unify the practice. I hope that we can one day we have like a guidelines for all the units in our countries and in Egypt, and we follow all of us same guidelines. No one is working by his head. We have a guidelines here. The guidelines is guideline. You cannot deviate from the guideline. You cannot put on your mind, oh, let me do like this. No, the nurse will come to you with the guideline telling you like this, the guideline saying like this, so then you cannot do anything. So just for we need to have a protocol, we have to have a policies, we have to have a guidelines. I know it is difficult, because you need a support, like support with organization, support with people who owe the money. I know we have very good hospitals in Egypt, and like الجمعية الشرعية, like I cannot mention the name because I unfortunately I didn't work for, now I left Egypt for now almost 23 years. So 19 years away from Egypt. I don't know how the practice improved. I cannot judge because I don't know. Long time ago I didn't work in Egypt, but with what I see, there is a lot of improvement in the teaching, a lot of support for junior colleague, and I hope everything will go in the right direction. So this is some of the references, and I'm telling you, the lung protective strategy, starting from the uh, the standardization of care, putting the baby on TTV, high frequency, non-invasive support is the superior now, to give or not to give surfactant. If you don't have surfactant, now all the guidelines start with like ventilation, then we assess the need for surfactant. Not all the baby we are give them surfactant from the first shot. Yeah. So the importance of patient-centered care in neonatology. Patient-centered care in neonatology prioritize the needs and preferences of families, fostering collaboration between healthcare providers. This approach enhances decision-making, promote emotional support, and improve outcome of preterm infant. Be honest when you speak to the families. Be honest on delivering the communication. Tell everything in a scientific way, in a lay language. يعني لما تيجي تشرح للأهل، اشرح لهم. الأهل يحبوا إنك تتكلم معاهم، تحب إنك تشرح لهم، تحب تقول لهم إيه الخطوة الجاية اللي هنعملها، لو حصل كذا هيحصل كذا، طب إحنا بنعمل كذا. This is building the trust. You will not imagine how here the interaction between the parents and the staff. And the thing that's annoying us, it is the standard of care. We receive call from the family at 3 a.m., 4 a.m., 5 a.m. How is my baby now? Then the nursing staff, he have a desaturation at 2 o'clock, which didn't require any stimulation. Then he have a desaturation. His saturation reached up to 40%, and we need to new puff him. And he had passed his stool. I changed the nappy, but he was not. Everything, they are telling everything, and these things build the trust between the patient and the team. And building the trust need good communication. We need to work in our communication. The patient has the right to know everything about his patient. The patient has the right to know about what next step you'll do. If complication happens, what we'll do. If there is IVH, what I will do. If there is ROP, what I will do. The patient has the right to know everything, and we should explain everything by smile, by heart. Explain everything. We we sometimes face a problem because we have a limited resources. If I have a limited resource, what I can do. So building the trust between the patients and the team come with being like really explaining everything, being very honest, and tell everything about the patient. Don't one of the things that we learn from Saudi Arabia, the first thing that I learned there, if you don't know, say I don't know. And many people know. If you don't know, please say I don't know. Even in the communication scenario, if the family or the patient ask you as question you don't know, don't uh, don't don't create an answer. Say I don't know. Actually, I will go and review and I will tell you the answer. Because now patient, you are facing patient who know everything. Now if you tell this patient having IVH, then you'll go and search about chat GPT or whatever, Google or whatever. You tell, oh, this is grade 1, grade 2, grade 3, whatever. Do you know, sometimes you know a difficult question, you need to to have the heart to accept their question and answer them. If you don't know, say I don't know. I go and review. uh, we we are building our knowledge from the challenging question between among colleague ourselves, between the consultant and the registrar and the SHO. We're building our knowledge by asking a challenging question, by also sometimes the patient will, you face a difficult patient, and you need to how to convince, how to counsel a difficult patient or difficult parent. These things you need to every time spend some, like if you spend only 1 hour reading any new article or any chapter of any book. Imagine after 1 month you have a 30-hour reading. After 1 year you will have 36 365-hour reading, and this is building your knowledge. This was advice from Dr. Adel Sadiq when he met us in the when we went to Port Said before starting our GP اللي هي كنا نسميها ايه الوحدات الصحيه. رحنا بورسعيد، قعدنا مع الدكتور عادل صادق، قال كانت النصيحه الوحيده the only advice from دكتور عادل صادق that you specify 1 hour per day for reading. Definitely all of us regret that we didn't do what he said. Global perspective on neonatal care. This we our lecture near to finish our presentation. We have disparities in mortality rates. It depends on the what you have, what standard you care of you have, what resources you have, how you access the services you have. Because most of the neonatal unit work in multidisciplinary approach. Like you have a surgical team, you have the cardiology team, the neurology team, the physiotherapy team, the dietitian, the pharmacist, the clinical pharmacist. It is not like the PN, the bespoke PN, the pharmacist preparing bespoke PN, or the ordinary PN. It is a multidisciplinary team. It is not a one man show. It is a multidisciplinary team. So working in a tertiary care unit, it is totally different from working in a level 1 unit. You need to have the communication between level 1, level 2, and level 3 unit. Balancing treatment and the quality of life, we talked about it. Challenging of aggressive interventions. That's why the DNR policies come out. Here we have the what's called this withdrawal of support if all the intensive care unit fail to improve the patient oxygenation or whatever. So we have the withdrawal care, which is not in our country, but we have the DNR policies We need to explain the parents about the outcome, the challenges, the sometimes nothing to be done, and we balance the treatment and the quality of life. And it is challenging, and from the religion point of view, and from the medical point of view also. Improvement in communication, we talk about it, and the continuous learning environment. Thank you, E.U.P, for the continuous learning environment you are achieving. Improving of community support for families and preterm infant. We have here what's stork program. They teach the family before going home. They answer all the question, like the back to back sleeping regime, the PLS, how when the baby have colic, what you do, when your baby had a problem, what you do. A lot of engagement from the community, a lot of videos explaining the shocking, how to manage shock, how to do basic life support for your baby. A lot of interaction between the community. You have the health visitor, a lot of, like, baby will go home, the health visitor visit him, then you have any concern, they send baby back to the hospital. The system, we need to build up a system which care of the baby on the hospital and when the baby go home also. Importance of monitoring long-term outcomes. So the BBD is one of the things that now the challenges because of the more survival for RDS. So the final thought: significant progress in the outcome. The advancement in neonatal respiratory care have significantly improved outcome for preterm infant, demonstrating the impact of research, clinical practice over decade. Innovative approach are key, like improvement in the skill of resuscitation, improvement of the ventilation strategy, improvement in nutrition, improvement on monitoring like focus, and the global knowledge transfer matters. So now it is only one click, and you know what is the guidelines in certain hospital, like Cincinnati Hospital or Minnesota Hospital. You know the guidelines now. Scotland guideline, UK guidelines, Saudi Arabia guidelines, Chinese guidelines, Japan guidelines. Now everything became easy, but you are limited by the resources you have, so you can adjust this for the resources that you have. Thank you. I'm very delighted to give this overview, and I hope you enjoy. Although I don't know how much you are attending, is it good or bad? So thank you, E.U.P, and we open to the questions if we have.
شكرا جزيلا دكتور طارق. هم بيشكروا حضرتك في الشات يعني عشان مش متاح لهم المايك.
تمام. شكرا يا سلسبيل، جزاكم الله خيرا. سوما، thank you so much. حسن، ألف شكر. لو في أي أسئلة في أي بارت في النيوتولوجي I'm ready. وإن شاء الله أنا ناوي أبعت فيدباك فورم هنحطه برضو على E.U.P. الفيدباك يهمني جدا، وإحنا بنتعلم من أخطائنا، بنتعلم إزاي to improve our coming lecture. دي overview، محاضرة overview، لكن بعد كده ممكن نتكلم بقى على أي بارت أنتوا تحبوه، أو لو أي اقتراح منكم نحب نتكلم فيه. I am always ready.
تمام ان شاء الله يا دكتور. شكرا جزيلا لحضرتك.
الله يبارك فيك.
كان في سؤال بس عن ريفرنسز تاني يعني.
الريفرنسز حطها تاني على الليكشر. طبعا انت لو دخلت على البريتزي وكتبت اسم الليكشر هتطلع لك. لو انتوا شايفين البريتزي ابلكيشن اللي انا عامل عليه، لان انا عاملها بابليك، هتلاقي كل الحاجات اللي انا عاملها على البريتزي البريتزي اهو، انت اكتب بريتزي واكتب عنوان المحاضره هتطلع لك لانها بابليك، وتشوفها تاني وتحمل، يعني مش عارف تحملها بقى او
تمام تمام زي الفل.
تمام.
كان في سؤال برضو عن لو في كتاب معين حضرتك ترشحه للميكانيكال فنتريشن.
والله انا بحب respiratory care of the newborn baby، ده احسن كتاب لان هو سيمبل وبيتكلم بقى طبعا ازاي لان اهم شابتر في الفنتليشن ان انت تفهم الباثوفيسيولوجي وازاي تعالج الديزيز بالباثوفيسيولوجي بتاعه. يعني ما ينفعش انا زي ما قلت كده السيتنج مش ثابته لكل الميكونيوم، غير الار دي اس، غير اللي بيبي عنده بالون هايبرتنشن، اللي عنده هيتروجينس باثولوجي، اللي عنده هوموجينس باثولوجي، اللي عنده كرونيك لانج ديزيز، اللي عنده بي اي اي تشينجز. الفنتليشن استراتيجي توتالي ديفرنت. والفنتليشن مش ان انت تزود الريت وتعلل الريت وتزود الماء، في احنا لا، الموضوع اكبر من كده، وفي جرافيكس وفي حاجات جميله. وانا شايف ان انتوا في كورس موازي في الفنتليشن، لكن ان شاء الله برضو مخطط ان انا اعمل كورس لنفسي باذن الله، وربنا يسهل ان شاء الله.
تمام يا دكتور. بالنسبة لإخبار الأهل بكل التفاصيل هنا هيكون مناسب في مصر، حضرتك شايف كده؟
ده اهم شيء في مصر، ده هي دي اللي لازم. احنا طبعا انا هتكلم من واقع التجربه. احنا وانا ليا كان زميل وانا لازم اذكر اسمه، لان احنا طبعا كان ما بدانا ريزيدنسي، بدانا في مستشفى، انا كنت نيوناتولوجي ريزيدنسي ريزيدنت في مستشفى اسمها مستشفى الفاشن المركزي، دي تبع بن سويف. وكان زميلي الفاضل الدكتور عماد علي، وان من اوف ذا فيجرز ناو في البيدياتريك فيلد في بن سويف، يعني في مركز بيبا. انا وعماد كنا مع بعض مثلا في الامتياز في مستشفى احمد ماهر امتياز، في القصر العيني امتياز، في ابو الريش. انا كنت من سعداء الحظ ان انا كنت سكني ايام الامتياز كنت ساكن في قدام مستشفى ابو الريش بتاع الطوارئ، فكنا بنقضي وقتنا الفاضي في طوارئ ابو الريش. فطبعا كنا بنشوف حاجات كتيره، والواحد طبعا شاف حاجات برضو، يعني كان في ناس تبقى جايه من اخر الدنيا وتلاقيك انت جاي تتعلم وانت اللي كنت بتشوفه بس. المهم يعني عماد كان انا اتعلمت منه طولة البال. طبيب الاطفال لازم يكون طويل البال، هما اتنين يكونوا طويل البال، يعني طبيب الاطفال وطبيب النساء، دول الاتنين اللي محتاجين طولة بال. طولة بال ان انت تقدر تشرح العيان اللي انت لازم تحكي للعيان. العيان هيثق فيك ازاي اذا كنتش انت بتحكي له كل المشكله؟ العيان مثلا انا لما كان بيجي لي عيان لما كنت شغال في مصر بقول له مثلا ممكن يحصل كذا، ولو حصل كذا تجي لي امتى، واحتمال يحصل تحسن، الحراره تستمر 5 ايام، لو الحراره استمرت، لو حصل رشح، لو حصل طفح جلدي ترجع لي تاني. انا قصدي ما انت لازم، انت لو انت عارف انت بتعالج ايه هتعرف تتكلم، لكن انت لو انت مش عارف انت بتعالج ايه او انت بتعمل ايه ما انت مش هتعرف تتكلم. لكن والله انا I was surprised they are telling the patient here everything. bus stool, he wins, he bus urine, he has desaturation, he has مش تراست بتيجي من كده. في الناس هنا مثلا بتدي مثلا رونج جنتامايسين دوز ولا اوفر دوز ولا اني اذر دوز اوف انتي بايوتيك، بنيجي في حاجه اسمها في خطاب اعتذار. الناس بتتقبل ان انت بتبقى يعني طبعا يعني مش هنوصل للمرحله دي دلوقتي في مصر، لكن في مصر انا عايز بس ايه، ان انت كطبيب اطفال ان انت بس بتعالج بتقول له كل حاجه من الالف للياء. دايما اتكلم مع الاهل، اتكلم مع الام، ده بتعمل تراست كويسه جدا ليك وللاهل، ان هم بيثقوا ان انت فعلا بتقول لهم كل كبيره وصغيره عن ابنهم ومش بتخبي عنهم حاجه. فدي بتنفع طبعا، حتى لو مش هتنفعك في يعني هتنفعك حتى في البرايفت بتاعك، لان انت هتبقى تراستبل دكتور.
تمام، شكرا جزيلا يا دكتور طارق، تعبنا حضرتك معانا.
لا بالعكس والله انا سعيد، انا اتمنى تكونوا استمتعتوا بالمحاضره. انا عارف ان يمكن الاكسبكتيشن انا فاكر نتكلم عن حاجه تانية بس على الفنتليشن، بس هي اوفر فيو اللي حصل في ذا باست والبريزنت والفيوتشر. يعني احنا دلوقتي داخلين على ريستيشن اوف 22 ويكس، ودي حاجه صراحه حاجه سبحان الله. يعني احنا كنا اخرنا كانت 24، دلوقتي ال 22 بلس 6 عايزينه يعيش دلوقتي.
بس هي محاضرة جميلة جدا يا دكتور طارق، تسلم ايد حضرتك.
الله يبارك فيك، الله يكرمك. وإن
وفي
شاء الله
انتظار
كده
المزيد إن شاء الله يعني، والمحاضرات المفصلة بعد كده إن شاء الله.
إن شاء الله التعاون يستمر، ودي يعني خطوة إن شاء الله معاكم على طول بإذن الله إن شاء الله. بس أنا من الناس اللي أحب تقول لي عايز تتكلم في إيه وأنا أتكلم، لكن يعني أنا أحب إن أنت تقترح عليا تحب تسمع إيه يعني كده. أنا
إن شاء
أنا
الله يا
تحبوا
دكتور.
تسمعوا إيه المرة الجاية وأنا جاهز يعني.
إن شاء الله يا دكتور، هنتابع مع بعض بإذن الله.
إن شاء الله بإذن الله.
شكرا. شكرا جزيلا.
شكرا.
مع السلامة.
مع السلامة. شكرا جزيلا. شكرا.